Now we are going to talk about the non-Hodgkin lymphoma. First, let's talk about the prevalence of non-Hodgkin lymphoma. Non-Hodgkin lymphoma is the fifth most popular malignancy in the world. Each year, more than 20,000 people could suffer from this disease. The number increased as the people get older. In the right part of the slide, you can see that the male patient is more than female patient. In recent years, from 1995 to 2015, the incidence rate of non-Hodgkin lymphoma keeps going up. The etiology and pathogenesis of non-Hodgkin lymphoma include virus infection, immunosuppression, bacterial infection, environment, and other factors such as immunodeficiency, rheumatoid arthritis, systemic lupus erythematosus. To be specific, such as Helicobacter pylori infection is related with mucosa-associated lymphatic tissue lymphoma and diffuse large B-cell lymphoma. HIV infection, EB virus, hepatitis C, and HTLV infection all play important roles in many different subtypes of lymphomas. Chlamydia infection is associated with ocular adnexal lymphoma. Human herpes virus 8 is related with primary infusion lymphoma. Borrelia infection is related with cutaneous mold lymphoma. Non-Hodgkin lymphoma include B-cell non-Hodgkin lymphoma and T-cell non-Hodgkin lymphoma. B-cell non-Hodgkin lymphoma is more than T-cell non-Hodgkin lymphoma. It's about 80 to 85%. Patients with non-Hodgkin lymphoma could start with painless lymphadenopathy. Sometimes the clinical presentation should be diversity and systemic. Many extranodal organs can be involved, such as spleen, bone marrow, nasopharynx, mediastinum, thyroid, gastrointestinal tract, skin, breast, testes, lung, central nervous system, skeleton, bladder, kidney, liver, and so on. Here are some pictures about the clinical presentation of patients with non-Hodgkin lymphoma. We can see the enlargement of superficial lymph nodes, tonsillar mass, and the ocular external mass. Gastrointestinal tract can also be involved. Under endoscopy, abnormal gastrointestinal mucosa can be seen. The thickened gastric wall can be seen on CT image. The kidney, leg, testes, and the central nervous system can also be involved. We can see the mass clearly. In splenic lymphoma, low-density lesions of different sizes can be seen on CT image. PET-CT shows obvious nucleate concentration and high metabolism. Mediastinal masses are also common, such as Hodgkin lymphoma, primary mediastinal large B-cell lymphoma. In this picture, we can see the mediastinal masses. To diagnose non-Hodgkin lymphoma, biopsy is the golden standard. We use different methods in different situations. Excisional tissue biopsy, cone needle biopsy, fine needle biopsy, all can be used. However, most of the time, excisional tissue biopsy is recommended because we can get the whole lymph node so that the pathological diagnosis would be easier to make. Meanwhile, some auxiliary techniques are also widely used in clinic, such as immunohistochemistry, flow cytometry, PCR for antigen receptor gene rearrangements, karyotype, FISH, or major translocation. Next, biochemical examination is necessary to evaluate the status of the disease, especially before chemotherapy. LDH and DO and beta-2 microglobin are two very important prognostic indicators of lymphoma. ESR should also be done. Coombs test. If the result is positive, it usually indicates hemolysis in B-cell lymphoma. Thus, glucocorticoid should be used. Hepatorenal function should be done before chemotherapy. Hepatitis B testing is necessary. You know that we should use target therapy like monoclonal antibody for CD20 positive B-cell lymphoma. Rituximab is the most famous CD20 monoclonal antibody and now is widely used in clinic. As for the image examination, we use ultrasonography, CT with contrast, including neck, chest, abdominal, pelvic. Of course, the most recommended imaging examination is the PET-CT. It can reflect both the biological and physical characteristics of the lesion. It provides the three-dimensional localization and characterization of the lesion, as well as the metabolic level. Bone marrow biopsy and aspirate are also needed for the first diagnosed patient to evaluate whether the bone marrow has been infiltrated. That's all. Thank you.